Welcome to the Golden Crane Award-winning Color Success Podcast. I'm your host, Dr. Stephanie J. Wong. Dr. Chris Nguyen is a geriatric neuropsychologist and assistant professor at The Ohio State University Wexner Medical Center. He completed his doctorate degree at the University of Iowa, an internship at the Ann Arbor VA Healthcare System, and a fellowship at the University of Oklahoma Health Sciences Center. He conducts neuropsychological evaluations with a wide range of patient populations and has a particular interest in dementia and other neurodegenerative diseases. His research interests include topics in cognitive aging, decision-making, civil capacities, and cross-cultural considerations in neuropsychology. Chris is a member of the American Psychological Association Committee on Aging and was recently elected to serve as president-elect of the Asian Neuropsychological Association. In his free time, Chris enjoys a good cup of coffee and spends time with friends and family. So I'm so excited to have Dr. Chris Nguyen on this show because he is an expert in neuropsychology and particularly with the Vietnamese community as well as the elderly community. Thank you so much, Chris, for being on the show today.
It's my pleasure being here. So thank you for the invitation.
Absolutely. I just wanted to kick it off. And if you could describe what is neuropsychology? It's such a fancy word, but I'm wondering if you can kind of enlighten us on more of a layperson's terms.
Absolutely. That's a really common question. It's a very specialized field. So it's typically, it gets confused with clinical psychologists or counseling psychologists and what they do. But neuropsychology is a specialty field that joins the medical fields of neurology, psychology, and psychiatry. The field is dedicated to the understanding of relationships between brain and behavior, such as when it's been disrupted by brain injury or psychological disorder. Mm-hmm. Unlike other specialties like neurology that relies on neuroimaging techniques, such as like MRI, CT scans, or EEG, where the focus on evaluating the structural integrity of the brain and the nervous systems, what we do in our evaluation is to assess how one's brain function changes as a result of brain injury, psychological disorder, or neurodevelopmental disorder, or neurodegenerative disorders. And so we use cognitive assessments, paper and pencil tests to examine those changes. And it's a process that can take up 2 hours to 8 hours of testing. It usually involves an interview with the patient and their family members, and then a very comprehensive review of the patient's medical history. We generate a comprehensive report that goes into details regarding the strengths and weaknesses that they present in terms of their cognitive profile. And then we use that to help with assessment, diagnosis, come up with treatment plans. Neuropsychological assessment involves.
So tell me a little bit more. There's so many aspects of neuropsychology. And so one of the things that commonly come up in my work is ADHD. So how do neuropsychologists examine ADHD? Because it's become a buzzword. Like I have ADHD when you don't have attention, and when you have attention issues or difficulty concentrating. So what would one kind of go through if they were being assessed for that?
It's a topic that neuropsychologists usually what they do is provide cognitive assessments. So for ADHD, it may not require a cognitive assessment to diagnose someone with ADHD. It is a neurological disorder in a context that it impacts someone's cognition or thinking abilities, but the assessment part of that will heavily rely on interview with the patient, usually a young child, history from their parents, or medical records or education records from their teachers, documenting behavior disruptions, things in an educational context. So some neuropsychologists are specialized in, but the broad course of our work is really more on neurodegenerative, neurodevelopmental strokes and cognitive, other cognitive dysfunctions. So
that's really helpful to know. Yeah. And you mentioned traumatic brain injury, which we've both worked with veterans. I still work with veterans. And so tell us a little bit more about how TBI impacts a person and what neuropsychologists do in terms of assessment.
That's a great question. Again, it's controversial in terms of what the patient presents with. Controversial in the context that some patients may experience a mild TBI, and that gets compounded with misdiagnosed of cognitive deficits. And usually we see this in a VA setting with patients, veterans who have mild traumatic head injuries, and if they get either misdiagnosed or misinformed that this is something that is permanent. So that changes their trajectory and their perceptions of their functioning years to come. So we assess, it would typically be the same assessment of cognitive tests. It depends on their severity of the TBI. Mm-hmm. If the TBI is severe, for example, if it injures the person's areas, brain structure where it impacts their language capacities, then the testing will involve more tests of speech and language abilities. So it depends on the TBI. It depends on the severity of the TBI. That informs our assessment. So how our assessment can be useful is that we determine their strengths and weaknesses. And so let's say if they have weaknesses in the areas of attention or concentration, or weaknesses in the area of memory, then it informs our recommendations. We provide recommendations that would target those weaknesses. We would refer them to programs such as cognitive rehabilitation program that they can work with their therapists to develop strategies to overcompensate those weaknesses. And so that's how a nurse psychologist can be helpful for patients with traumatic brain injury, is either providing education that it could be a mild injury that can not have a long-term cognitive consequence, or have an actual thorough evaluation to help to identify strengths and weaknesses and then inform treatment process. So that's how we can be helpful in that context.
Absolutely. And I think as younger and younger veterans are coming to the system, it becomes very complex. I mean, and a lot of providers are seeing more and more acuity in their symptoms, as well as comorbidity, meaning multiple diagnoses, mm-hmm. PTSD, bipolar disorder, all those kinds of things that they're facing. And so I imagine that integrative care is very, very important, and working with others in addition to your neuropsychologist. What other teams do neuropsychologists integrate with?
So I am in the Department of Psychiatry at the College of Medicine here. And so my role is to see patients across the medical centers from neurology, family medicine, in other community settings. We had external provider, but neuropsychologists are integrated in multiple teams. So for example, we have some of our faculty integrated into or do assessments for transplant patients.
Mm-hmm.
So this is assessing their cognitive capacity and psychological functioning pre-transplant to make sure that there's no cognitive deficits or emotional disturbances that could impact the recovery process. And so neuropsychologists are often embedded into those type of teams. We have faculty that are embedded in neuromodulation teams. So these are assessments for patients that will be undergoing deep brain stimulation for Parkinson's or essential tremors. So our role in that process is to make sure that there's no cognitive deficits that would interfere with their procedure, and then monitoring outcome. And so that's one area that we integrate. As you know, like in a VA setting, neuropsychology can be involved in multiple settings.
Yeah.
Some psychologists are trained with therapy, and so they can be involved in like a community living center, providing therapy for older adults, providing assessment of guardianship capacity, those type of assessments. Some psychologists. So I was trained at a VA where we do work with chronic pain. So we provide chronic interventions for chronic pain as well. And so it depends on their specialty of the neuropsychologist and his or her interests. But we're very versatile in the clinics that we can be embedded in.
Absolutely. And part of my reason for asking is to kind of put a carrot on the stick to people listening, is that we need more neuropsychologists, and there's so many things that you can do as a neuropsychologist. And you mentioned community living centers. And I think that's one of the things I was really interested in talking to you about, which is the aging population. Mm-hmm. We're seeing, obviously, don't want to overgeneralize, but boomers and like a lot of retired folks. And in Asian American culture, at least in my immediate community, it's kind of taboo to send your parents to a nursing home or a CLC. Mm-hmm. And so can you talk a little bit about that cultural piece and kind of what we can do to help our elderly, as they age?
Yeah. So that is, that's a very sensitive and tough topic to discuss for a family of Asian descent. As you know, our culture kind of encourages, or we're influenced by our culture in such a way that we take care of our parents or grandparents. And so having that discussion is difficult, of being able to having that tough discussion of sending a loved one to a nursing home is very difficult. And so it is for all cultures. Yeah. But, especially in our culture the stigma of not being able to take care of your older parents is one thing. Mm-hmm. But to some family, it comes down to values. So first, I think part of the discussion for me with a family member that's going through such a discussion is that what are their values? First, we as psychologists, we always promote the autonomy of our patients, our clients. So their needs come first. So what do they want? Do they want to be at home? Do they want to be independent in that context rather than going to the nursing home? So the decision-making process always have to see what they want. The second part of that, do they have their decision-making capacity to make that decision? And so that's another tough issue to navigate. Then it comes to, what do the family wants? What do they have the financial means to be able to do this? Right. And so that's another area to talk about. And then there's a component of acculturation, like what we do know is if a family member is here in the United States longer, they're more assimilated to the culture. So that discussion is easier. They're most likely to accept that process of having a family member in a nursing home versus someone that's newer in the country. So that's another context too. Then there's an issue of family dynamics. What we do know is if there's a family, if they're have high, if they have the means to do so, if there's conflict within the family member, different family members, that's a whole other issue that we have to navigate. So I don't have an easy response to this.
And I didn't imagine.
It's
It's complicated.
It's not a cop-out. It's complicated. But what I can say, it takes a faceted approach to this decision-making process. And I always see, putting my advocacy hat on and advocate for the patient to see what they want. And that's what I would focus.
And in terms of decision-making capacity, I wonder if we can dive a little bit deeper into that, because especially with cognitive disorders or dementia, there is that aspect of if they can't remember in terms of time or even recognize certain family members, and maybe there's like that flare of paranoia because they think, I've seen a lot towards more of the 80s and 90s age, that people get very paranoid about someone abusing them or like forcing them to do something, and which is really scary for the a relative who is trying to help. Can you speak more to that decision-making capacity and how maybe interventions, what is out there for family members as well as the patient?
Yeah, there's for psychologists or mental health practitioners who are working with older adult patients where you are concerned about their decision-making capacity. There are resources, and I can share there later on, language-based resources where you can use those guidelines to be able to determine what's best for the patient. Do they have capacity? If they don't at baseline, what resources would you refer to? So for example, a neuropsychologist would be someone who would come in and do a more thorough evaluation on the decision-making capacity and help with coordinating care. Perhaps their process, their delusion or illusions could be very acute. It could be in the context of a delirious episode. And so at that moment, they may not have decision-making capacity, but once that is resolved, then they have decision-making capacity. So involving a team of multiple providers to assess that process so that you're advocating for your patient. So we'll want to see if this is an acute process, if this is a long-standing process, if this is likely to get worse before we deem someone as not being able to make that decision. And as psychologists, as mental health workers, we provide their clinical opinion, our experts, and that's also this. Ultimately, that's something that a court or a judge would rule whether they are unable to make that decision or not. But to segue a bit, this is a good discussion about wills, about testaments, about power of attorney, about healthcare power of attorney. We don't talk about that. That issue is kind of less discussed among Asian patients, older adult patients.
Oh, I have a will.
Yeah, right.
I'm fairly young, I would say, for that. But I think as you talked about in terms of generations and, I'm third or fourth generation. And so I think it's really important for me to have it set up for my children in case something happens. And especially now in this COVID world,
exactly.
It's very uncertain. But how do you have that conversation with your family when, I didn't grow up talking about money or how much money my parents made or other people.
Right. It's tough to approach that, but just like the stigma of mental illness among Asian communities, the best way to resolve it is just to have a conversation, have an attempt at it. Or if you don't, that stigma persists. And so that it comes to with regards to healthcare power of attorney and advanced directives and all that planning, by having that settled, it becomes less of an item that you have to worry with when you get to that point. So to the extent that we can prepare a family as much as we can, it will ease that process for them when they are in that situation where they have to determine whether or not to make that decision for their parent or for their grandparent.
Yeah, and I can speak to being on the child side, right? Because my dad just had heart surgery and he's doing well. I mean, but he's staying with us until he can get back on his feet more independently. But from a child's perspective, it's like, I really encourage older Asian Americans to have these conversations with their kids, because the secrecy piece is a huge thing. They don't want to worry us, right? And so by the time something is wrong, it's like, oh, here's all the information. You're like, what the heck? You're just so blindsided. And I think there is, I guess, not as much worry leading up to something, but then when something happens, it's like a complete shock, right? And to have these conversations when there's a moment of crisis, it speaks to your point. It's like so much easier to have these conversations, even though they're uncomfortable, but when there's not a crisis, because emotions aren't as high. Right.
So we can have these conversations now. We understand that it's difficult, with our within our communities to talk about death, to talk about planning, things like that for the future, and to talk about mental health, to talk about nursing homes placement, but we can advocate for these changes within our community, and that's why we're having this conversation, me and you right now. Is the more we have these conversations, it becomes normalized with our peers, with our friends, with their friends. And so that's how I can see that we can create these changes, is by these conversations. We're bringing to light some of these issues that's very difficult to talk about in the Asian communities.
Well, and I know you have juice in the community, the academic community, the Vietnamese community. So I'm sure this is going to be distributed to get more people starting to talk about it. So, I mean, I'm wondering if you can speak a little bit more about the work that you're doing in the community, particularly, the buzzword always is culturally responsive care, being culturally humble. But what does that really mean? And how have you tailored some of the approaches to consider Vietnamese culture, Asian culture?
It comes to that buzzword, and the buzzword of DEI, and all these efforts, as academic from an ethnic minority background. Sometimes our task was take on all these initiatives, whether we like it or not.
Yeah,
it falls on us. And some of that burden is external, of course, and some of that is there's a balance between external and internal pressure of representing your community and fighting for the change that our community deserves. So what some of the things that we're doing is that in the neuropsych community, there's assessments, there's cognitive assessments, there's these tests that are developed by Western societies, are normed in Western societies. So it's not appropriate to use those same tests for a patient of a culturally diverse background. So you can't take that same test and apply it for a patient of Vietnamese descent, Chinese descent, and it would be the same, even though if it's translated, the context is not the same. And so our work is to develop new measures that are more culturally sensitive for the population that we're serving. And so my role in some of the organizations that I'm involved in is doing that, is having that discussion that we need to develop new measures we need to collect normative data among the patients of our communities and not rely on pre-existing normative data. So that's the one part. The next one of the aspects of promoting healthcare and reducing stigma is to have more education on topics of mental disease, mental illnesses like depression, anxiety, PTSD.
Right.
Talk about it in a context that is tangible for the patient, for the client, that is healthcare, that is not something that is due to events that you can't control, or like beliefs that are outdated, or part of the conversation that contributes to the stigma is not knowing the neurobiological causes of some of these mental health disorders. And so how do we take that knowledge and put it into a format that we can communicate to our communities? And so providing the education can reduce the stigma. And so that's another component of what we're doing is it's doing more of that in our communities.
What's an example of maybe a nuance that may not be included in more Eurocentric testing?
So, for example, we're developing a test that measures language abilities. Confrontation naming is one aspect of language functioning. So that's like if I show you a clock, or if I show you a calculator, or if I show you a stapler, can you say what it is within a few seconds? Can you retrieve what that word is and say it to me? But like for someone with lower education, someone that is in a context where they don't know what a stapler is, if you show that to them, they don't know what it is. And so that is not a language deficit on their part, because your stimuli is not culturally congruent. And so all part of developing a confrontational naming test is what are some of their tools in Vietnam that people use? What are some of their writing utensil that's more appropriate? So we can develop that naming test specifically for an adult in Vietnam who doesn't have the level of education that the normative data would suggest.
What a great example. Well, now that we talked about the nerdy stuff, which I and Caroline and you love, I also wanted to dig deep into your story, though, because you have such a rich background. I mean, how did you even get into neuropsychology? And if you can even talk about your immigration story and so forth.
Yeah, that's it's what I can sum up about how I got here, of being in academia as a clinical neuropsychologist, is first, just being open to the opportunity that comes up, being flexible, being curious, and being prepared for those opportunities once that it presented to you. So I was born and raised in Vietnam. We came here with literally the clothes on our back, with my parents and a younger sister. And we immigrated. We came to Iowa. For those of you who don't know where that is, it's in the middle of the country. It's in the middle of the country. And so that's where we came to.
Why Iowa, by the way? Just curious, because I mean, we're in California, so there's some historical background, but like, what led you guys to Iowa?
It's what that when we were in the refugee center, what they asked us they asked my dad that if we knew anyone in the United States. My dad feared that if we said no, they would return it to Vietnam. And so he basically had to think and dig really deep of if we know anyone. And so the tie to Iowa is that we had someone living in Iowa who went to middle school with my dad's older brother 4 decades ago. And so he just kind of came up with that name, and they kind of assigned us to go to Iowa. I mean, with their hope that, we knew someone in Iowa, so our assimilation will be easier than just sending us to somewhere that we don't know anyone. Otherwise, if we don't have family or friends, it's usually to some major metropolitan area, like in California, in Texas, in Boston. But that's our story. That how we got to Iowa.
How old were you when you came here?
I was about 7 or 8. Yeah, and my sister's 3 years younger.
Were there many Vietnamese there or Asian Americans?
Oh, surprisingly, the community, there's a good amount. There's a couple hundred families, and so it's not too bad. So we grew up in Iowa. I went to all the public schools in Iowa, and then settled with the University of Iowa for my education. And there's a period where I was in the Iowa National Guard as a combat medic for a few years. And after that, I came back and attended the university for pre-med, and found out that, that wasn't for me. So I did a couple of courses in management, business administration. So I love that entrepreneur type of mindset. And so for a while, I opened and operated 3 coffee shops at their local college campus, and did that for about 3 years. Sold those shops and going back to school, and that began my trajectory into grad school of becoming a neuropsychologist.
That's amazing. And I know Caroline had mentioned that. And well, first, thank you for your service, because I think it's, you've given so much to the country and you continue to give back. And the other part is, wow, that is really Vietnamese style, like building a business, selling the business. And so I thought that was so interesting, because you were talking about, the confrontation naming task. And it's like, yeah, I mean, if you give people complex math problems in a standardized test, they may not have the education, but hey, ask my mother-in-law how you get a deal, or like,
Right.
manage the books. And she is just so sharp.
Right.
And so now fast forward, you're in, grad school, you eventually do become a doctor. And what is it like, though, to be an ethnic minority in this field and kind of be more front facing when you're having these discussions and building these tools and so forth?
Yeah, there's again, you're having, these are these are great questions. You're putting me to work today.
I'm sorry.
Yeah, we kind of we touched on this earlier, that as an ethnic minority academic, we are just kind of the face of our community, and so most of the times there's that pressure of representing community and serving on these diversity communities where we're at, contributing to issues of diversity, equity, and inclusion. So those are some of the tasks that is a part of what we're doing. Some of the other challenges that we've been trying to highlight across several organizations in neuropsychology and psychology is that there is this presence of microaggressions, and that's something that I don't want to shy away from. It's not something I want to sweep under the rug because it impacts all of us, because it impacts the work. It's impact our sense of self if we don't talk about this, if we don't get the support. So part of that is that that stimulus value that I bring to every single session, or it's that. So confronting that when it comes up in a way that is meaningful for you, for your trainee, and for the patient. So that does come up from time to time, and that's something that a psychologist from a non-minority psychologist don't think about. That's something we deal with on a day-to-day basis. We deal with issues of imposter syndrome sometimes. There's this internal belief that you don't belong. And so sometime as an underrepresented minority faculty, that comes up from time to time. And so those are some of the things that I constantly not only check in process for myself, but also to make sure that my trainees, some of which are also underrepresented minorities, have a safe space to talk to me about that too. So did that answer your question?
Absolutely.
I felt like we went on a tangent.
No, I think it's really important just to summarize. When one, microaggressions are these slights that may not be so obvious. It's like when people ask you, like, where are you from? Where do you live? And I mean, you were born in Vietnam, but for me, I was born here. And so I say, America, what's your nationality? American. But right. I think we're doing such important work because our stimulus value, yes, I mean, you can't hide your face. Mm-hmm. We know that we're Asian American, and, by nature, the work is important because we represent so much to mm-hmm. so many people. And mm-hmm. I didn't realize that until people were writing me about the show and just saying, like, it's so amazing to see two powerful Asian American women, putting out information. And it's like, you don't really know until, for you as well, like having trainees, they probably turn to you for all sorts of advice, and just your mere mm-hmm. existence and experience means so much to them.
Right.
So if you can kind of give a message to the community, or even, not just the Vietnamese community, but just in general, what message would you like to convey?
In how many characters?
You have unlimited space. I know it's a right. tough thing, but I think your word, and not to put pressure on you, but I think you can have a continued huge impact for the community.
Yeah. Well, there's a couple of layers. First, I think that to reduce the stigma of mental health in our communities, we have to talk about it. We in academia have to advocate for resources for our communities. We have to advocate for our institutions to provide the resources for our communities. That could be language-based resources, translators, translations. We have to advocate for institutions to have a strong pipeline of clinicians that look like us, that are from our own community, so we are well represented. And so, as clinicians and as leaders in the field, I think that those are some of our responsibilities to reduce stigma and to increase this resource for our community. We have to change the narrative that mental health care is an illness. We have to change that narrative and speak of it as health care, and rather mental health and anything that the negative connotation that comes along with it. It is health. It's health. It's health. It's health.
Yeah.
So talk about that in terms of that context. We take our car into a mechanic every 6 months to get our oil change. at the very least.
If you're good about it.
If you're good about it, right? So do that for your body, do that for your healthcare. So more of that, just kind of that routine checkup on your mental, emotional, behavioral health goes a long way in preventative medicine.
Yes.
And last, let's build a community. Let's support each other. Let's talk about these difficult issues that we have alluded to tonight. Microaggressions, issue of disparity, issue of racisms.
Yes.
So these are all major topics that we cannot talk about in 1 hour. And so the conversation should continue within our own communities and which our own networks. And so those are just kind of some of my main points that I want to convey.
Yeah, this will be great when you play for your trainees and you're like, well, what do you think about this? But lastly, to end on a fun note, I mean, how do you self-care? That's a buzzword, but how do you, engage in leisure activities and deal with some of this pressure? Because it can't be thinking about complex issues all the time. We have to have an outlet.
Yeah. Thank you for bringing that up, self-care, because it's so important. That is the maintenance that I was alluding to. That is bringing your car to the mechanic every 6 months. But as specifically for mental health care providers, for clinicians, for doctors, for nurses, for dentists, we see patients every day. We hold our patient, we hold their fears, their anxiety about their health. And if we don't find a balance in our life, we don't find things that we enjoy doing, it could lead to burnout.
Yes.
And especially in our mental health field, it's well known that it's associated with burnout. And so if we don't take care of ourselves, we can't take care of our patients and our families and our students and our trainees. So that is so important that we do that and think of it as professional competence, that it's very deliberate, that we integrate that into day-to-day activities. And, it's fun for us, doing the things that you love, doing the thing that you enjoy doing. And so that's just one bonus of self-care.
And for leaders to encourage that too, because I think a lot of times people will say that, but just really walking the walk and really encouraging students, trainees, your employees to take the time. I mean, I'm huge on saying, take a mental health day. And we come from a clinical background. So it's like mental health there's parity with physical health. And so you need to take that time, but not all people think that way. And I think there needs to be a shift in that, to really let people know that it's okay to quote unquote call in sick because you're just not feeling up to it. And it being okay and not stigmatized.
That's a good point. You are sometimes in a position of power to create that change, because the system is not balanced. Trainees, med students, they know that they have to work hard. They have to do all this stuff to get to the next check mark in their training curriculum. So if you in that position don't talk about that, don't model it, to them it's not an important piece of the whole process, of the whole puzzle for them.
Right.
So you have to advocate for that and talk about that and model it.
And I say every good therapist has a therapist. So I'm putting that out there, because if you are helping clients, there's a need for processing your own stuff, what you're bringing to the room, going back to what you said, the stimulus value, and understanding how that's interacting with the person sitting in front of you or the family sitting in front of you. So, well, Chris, this is flown by, and I'm just so grateful that we got connected, and I'm sure we'll be having many more conversations, and hopefully when I'm over visiting Caroline, we can catch up. But thank you so much for taking the time today.
Of course. Thank you very much.
Thank you so much for listening to the Color Success Podcast. Listen, like, subscribe on all major streaming platforms, YouTube, IG, and if you want exclusive content, you can join our Patreon. All links can be found at colorofsuccesspodcast.com.